I'd like to welcome you all to this seminar on hybrid closed loop and specifically the MiniMed 670G system. My name is Fran Kaufman. I'm a pediatric endocrinologist and the Chief Medical Officer at Medtronic Diabetes. So what this slide shows is the fundamental premise of hybrid closed loop therapy, where we're actually shifting the variability of basal insulin delivery, making it much more dynamic in the attempt to markedly improve glucose control. And we're doing that because we're trying to mimic normal physiology, where without diabetes, pancreatic insulin secretion is quite variable throughout the day and night. And of course, that results in the non-diabetes state in very tight glucose control. Now, with exogenous insulin delivery, either through MDI or insulin pump therapy, what we have is relatively fixed insulin, and we still have extreme variability of glucose control. So with standard pump therapy, there's little variability of the programmed basal rates, and as a result, we have too much variability of glucose. With the MiniMed 670G system, we see great variability, dynamic insulin delivery for basal, and as a result, tighter glucose control with more time in the target range. We performed a pivotal trial with our 670G system, and it showed exactly that. We had improved glucose control, decreased glycemic variability, minimization of lows, and reduction in hemoglobin A1C. So I want to show you on this slide what has been the path that we've taken at Medtronic to actually get to our hybrid closed loop system. So first we developed the sensor augmented pump as a platform upon which we could build automation of insulin delivery. Then we went to the suspend on low system and showed, and you can see in that black bar across, what are the evidence build that we've been involved with, our own clinical trials, supporting external investigators' clinical trials, to be able to have a body of evidence for you and your patients so you can decide what appropriate therapy really is for any individual you care for. So suspend on low through our Aspire trial, both in clinic and in home, showed a 35% reduction in low sensor glucose values and a stable A1C. And then we have now a suspend before low system. It's not available in the United States, but is outside the US. And now this not only mitigates the exposure to hypoglycemia, but by suspending insulin in anticipation of hitting the target within 30 minutes, we actually can prevent hypoglycemia. And studies have shown between 60 and 80% of the time. But those two are about suspending insulin. Where the real improvement comes now is, can we actually deliver basal insulin? And that's what hybrid closed loop auto mode therapy is about. And in our pivotal trial, we showed that we could reduce again the A1C, reduce glycemic variability, and I will walk through how that trial was conducted and the results as we go through this slide deck. So we have done it originally in 14 to 75-year-olds. We're now in the midst of a pediatric pivotal trial, likely going down to age 2, and we've got planned a 1,000-patient global trial where we will randomize 3 cohorts from MDI, from pump alone, from pump and sensors against closed loop therapy, and then see the difference in outcomes. So we're very excited about continuing an evidence build so that you and your patients can know what to expect from this advanced therapy. So what are the components of the MiniMed 670G system? Well, at the center, of course, is the pump itself, and this is our new pump platform. We're really excited about this platform. It has a bigger screen, many colors involved. It has a menu that's actually more driven to enable the patient to understand what the next step, and the next step is to do for their insulin therapy. It is waterproof and has a lot more functionality, so we're very excited to build upon this platform our automation of insulin delivery. Now, this is a system, so it's linked with the Guardian Sensor 3, and that, of course, uses a Guardian Link 3 transmitter. And this duo is 2 generations from where we are now in the United States, and we've done a pivotal trial. The FDA has looked at that pivotal trial results and believes the accuracy of this sensor enables us to drive hybrid closed-loop therapy. And I'll get a little bit more about the sensor itself as we go on. It uses a one-press inserter. We're very excited about new CareLink software that will hone in specifically on the hybrid closed-loop therapy. I'll show you exactly what that looks like, and we'll go over actually an actual case. And the system uses a Contour NextLink 2.4 blood glucose monitoring system, and this is used to calibrate the sensor and to obtain BG measurements before boluses are given. So just want to get a little bit more into the Guardian Sensor 3 and the Guardian Link 3 transmitter. So this is a system that now has an extended wear up to 7 days. And what's exciting about this sensor is it has a chip in the transmitter actually that looks at sensor values, and it's looking for sensor glucose drift. Compared to the iSig, the raw signal, as well as a cal factor that is inside the transmitter and changing as time goes on. And if it sees the sensor drifting, then it may ask for another calibration. So this has enabled us to cut down on outliers from sensor data, and this of course makes it very safe to run hybrid closed-loop therapy. And looking at the accuracy of the sensor itself, the way we measure accuracy is something called MARD, the mean absolute relative difference between the sensor data and simultaneous venous blood sampling, which is done with a Yellow Springs instrument or a YSI. And when we have 3 to 4 calibrations a day, which is what we are recommending for the system, the MARD is 9.64. With 2 calibrations a day, which is the minimal calibration scheme that can be used for the sensor, then the MARD is 10.5. So these show that the sensor has good accuracy. We're taking out outliers and a 7-day wear, so we're very excited about this sensor as part of the hybrid closed-loop system. And this is to show you how it actually all looks on paper. So at the top part is a sensor tracing, and right through that sensor tracing you can see a pink line. That's at 120 milligrams per deciliter. That is where the target is for the hybrid closed-loop system. And if you look below, you can see the delivery of insulin. This happens to be an overnight tracing. The blue line is actually the preset basal rates that one would be using in open loop. And the dynamic up and down lines are actually the delivery of insulin by the algorithm itself. You can see sometimes there's peaks, sometimes there's no insulin delivery, and this is dynamic in response to sensor glucose data running through the algorithm and directing every 5 minutes how much insulin the device will deliver. So if we look at, again, how does this actually respond? So this is a build slide, so we'll start with the sensor glucose values decreasing and then increasing, and you can see as a result this very dynamic delivery of insulin below, where there's times where it's decreasing, it goes to 0, it goes to the maximal amount of insulin that can be delivered, and this maximum amount is calculated by the algorithm and the system itself and reset every day. So there's an adaptation that looks at the last day's delivery of insulin as well as a 6-day span, actually can go into 14 days, so that it can determine what is needed and that it can dynamically change over time. So now let me get into the pivotal trial itself. And so we had been in a very, very good relationship and going back and forth for quite some time with the FDA, showing them results that we have been building upon over a decade of feasibility data with our algorithm, and then as we built the system with the system itself. As a result of seeing all of this data and all of the feasibility studies we had done, they allowed us to do a non-randomized pre-post study for our pivotal trial. This study involved 10 sites, involved only those with type 1 diabetes greater than 2 years and with an A1C less than 10%. As you can see, there were 2 age cohorts, adolescents 14 to 21 years of age, adults 22 to 75 years of age. All of the participants were on pump therapy for 6 months or more and either used or did not use CGM. It turns out about 2/3 of the adults used CGM and about a half of the adolescent cohort were already using CGM at the time of the study. There was a run-in phase in which they were in open loop, or what we're going to be calling manual mode, and that lasted 2 weeks. And this was followed by a study phase, closed loop, or what we're going to be calling auto mode, and that lasted 3 months. And during that 3-month time period, all the participants came in for a hotel stay, 6 days, 5 nights. Actually, it turned out to be mainly Airbnbs. And during that time period, we observed them, we had them exercise, we looked at meal patterns, but most importantly, we had them for a 24-hour time period have a sampling, a frequent sampling of the sensor data against a venous reference sample using the iStat machine. And a third of them came in the first month, a third of them came in the second month, and a third of them came in the third month of the study period. In the table, you can see the characteristics of the adolescent and adult cohorts, a very typical type 1 population, long duration of diabetes, typical total daily dose of insulin, and an A1C for the adolescents at baseline of 7.7, and for the adults of 7.3, although I do want to tell you there was a spread all the way to above 9.5. At the bottom, you can see the overall schema, that run-in period for 2 weeks, some teaching of how to use auto mode, and then the study period for 3 months. So this is the results of the study, looking at the A1C at baseline and then at the end of the study period. So the baseline or run-in is in the black, the end of the study is in the gray, and I think you can appreciate that there's been a shift to the left of the A1C distribution for this cohort. And if you look at the number who were at or below 7% for A1C, at baseline it was 38%, and at the end of the study almost doubled at 62%. And the overall mean A1C was 7.4, and at the end of the study, 6.9. I think we can probably all admit that there are few studies in a large cohort of type 1 patients in which we can get the mean A1C below the target of 7. And then most importantly as well, during this study, there were no severe adverse events related to the device, specifically 0 episodes of severe hypoglycemia and 0 episodes of diabetic ketoacidosis. Now this slide kind of shows another way to look at important outcomes, and this is the sensor glucose distribution. So if we look across those panels, all patients, adults, and adolescents, we've split them up because they're a little bit different, adults and adolescents, as if we all didn't know that already. So for all the patients, the adults and the adolescents, the x-axis is time of day, midnight to midnight. The y-axis is sensor glucose, milligrams per deciliter. And so if we start at looking at that initial midnight time period, we see a gradual decrement of the sensor glucose tracing in the closed loop period, and which is in the pink, and the background is the gray of the open loop period. And I think you can see right off the bat that that open loop period has much more glycemic variability, much wider spread of the sensor glucose data compared to the closed loop or auto mode period. So if we look at night, we see this gradual decrease to the nadir of the fasting glucose. And then we see a hump for breakfast, a hump for lunch, a hump for dinner. Particularly in the adults and in the adolescents, we see that breakfast, that lunch, and then a suggestion that the adolescents are actually eating all the time from after school until they go to bed. So at night, we can see that there's a mitigation compared to the open loop gray of manual mode. That auto mode in the pink shows us a mitigation of both hyper and hypoglycemia at night. And for the adults, we see mainly a mitigation of hypoglycemia during the day. And for the adolescents, we see mainly a mitigation of hyperglycemia, indicating, of course, that this device will address whatever the glycemic aberration actually is. And then if we look above, there's some data that is very important for you to understand, and that all subjects were in auto mode. So they were using the hybrid closed loop system, having that deliver their basal insulin automatically 87% of the time. Adolescents were a little bit less compared to the adults, but that's true with the utilization of all diabetes technology, in that adolescents use it less than adults. So this is another way to display the same data set in table form. So we could look at the 24-hour period or the nighttime alone, and we can look at high sensor glucose values. The 70 to 180 is the in target range, and then the low sensor glucose values below 70 and below 50. I'm sure you can appreciate that there is a reduction of both the high and the low for these cohorts during the 24-hour time period as well as at night, and an increase in time spent in the target range of 71 to 180. A greater increase during the nighttime when the device is actually now a little bit freed up from those mealtime boluses, freed up from exercise, and where it's doing most of its activity with basal insulin delivery. However, I do want to tell you that, surprising to me, in looking at all this data, people eat a lot in the middle of the night, and I think people aren't necessarily sleeping through the night, so this will entail what happens in real life with a cohort of 124 people living their lives at home. Then importantly is that within day standard deviation, or SD, line at the bottom of the table, standard deviation is a measure of glycemic variability, and we see a significant drop in glycemic variability in this study as well. And we could use this measure. We could look at coefficient of variation and other measures of glycemic variability, which all improved in the auto mode phase compared to the manual mode phase. So this slide actually shows this in another way. So in the graphs on the left, we're looking at the overnight time period, 10 p.m. to 7 a.m. Across the x-axis, again, is time. On the y-axis is the interquartile range on the top for sensor glucose data, and the interquartile range on the bottom for insulin delivery rate. So we can see the gray again is the manual mode or open loop, and we can see for those sensor glucose values, there is quite an extreme variability throughout the entire nighttime period. And then we can look at the pink on top and see that we have narrowed that glycemic excursion for the glucose values. We brought them down as a mean, and we're getting close to that 120 target that the device is trying to get the sensor glucose data to. So a reduction of variability of glucose values. Now look below and we can say the exact opposite happens for insulin. So the pink is the delivery of insulin in auto mode or hybrid closed loop, and the gray band in the center of that is the delivery of insulin in manual mode or open loop. And I think you can appreciate that now there's a lot of variability of insulin delivery that goes on throughout the nighttime period compared to the manual mode where we have very tight insulin excursions. We've got a flat basal rate. And what we're doing in now closed loop is we're getting dynamic insulin delivery. And that dynamic insulin delivery is responsible for what's happening on top, which is I'm narrowing glycemic variability. So the pie chart says it in another way. So this is looking at the sensor data for all the nights and saying on average, this device for 100 minutes at night delivers 0 insulin. Now, it's not 100 minutes altogether. It's 100 minutes spread out throughout this time period of night. And at the same time, for 175 minutes, it's delivering the maximal amount of insulin. And again, this maximal amount of insulin is determined by the algorithm itself and adapted daily. That's half the night. The rest of the nighttime period, it's delivering pretty much equally between 1 to 24%, 25 to 49%, 50 to 74%, and 75 to 99%. So lots of dynamic in that insulin delivery overnight. So what does that actually look like? This is from a single patient, 4 nights in a single week. So first we look at the sensor tracings on top, and we see that, boy, they're pretty even. They're pretty close to that 120 milligram per deciliter pink line that the device is targeting the sensor glucose value to. Then we look below and we see now this rise and fall of the insulin delivery, particularly compared to that blue line, which would be what would be delivered in manual mode or open loop from the preset basal rates. And you can see how much more dynamic, at times significantly increased from the basal rate, at times to 0. And not one night looks like another nighttime pattern. So extreme variability of insulin to get that glucose value as tight as can be during the nighttime period. So I do want to show you this slide because I told you that we had the patients come into the hotel and that we did a comparison between the center data and simultaneous venous blood obtained with the iStat machine. And I think you can appreciate that the distribution of the venous glucose compared to the sensor glucose is essentially the same. So this is really important because if you really look at evaluating the system with the sensor glucose data, we have to admit that the sensor itself is part of the system, and it's always hard to evaluate a system with one of its components. So this takes us now out to an independent evaluation and shows that the outcome is essentially the same as what the sensor inside the system is telling us for glucose distribution. So I do want to admit, as always, there's limitations to any study that any one of us can ever do. The limitations for this are that it was not controlled. It was a single arm. It was a pre-post study. There was also some data quantity imbalance between the run-in phase and the study phases. There's always exclusion criteria for participants in a study, and that always leads into question, how translatable is this to the entire type 1 population? On the other hand, there's many study strengths. It was multi-center, there's a large number of subjects, both adolescents and adults, 3 months at home, unsupervised, people living their lives now with the automatic delivery of insulin through a closed-loop system. The other strength is that sensor accuracy was confirmed by the iStat reference value. And of course, the FDA saw the results of this study and felt that it supported the device safety, and as a result, allowed us to commercialize our MiniMed 670G system. The summary of the study findings is that proven safety with no severe hypoglycemia or diabetic ketoacidosis, and that the study phase compared to the run-in results show an increased time in target, decreased glycemic variability, those lows and highs diminishing, and a reduction of A1C. Pretty excited about what we're doing next steps. So we came close at some point to ending this trial, and we were informed by the patients that they did not intend to give us back the devices. So they solicited the FDA themselves to say, we want a continued access program, and of course we were more than ecstatic to work with the agency as well as the patients and the investigators to be able to provide the continued access program. So about 80% of the participants went into the continued access program, and as a result now we have greater than 50,000 days of patient exposure, over 130 patient years equivalent. That's 130 patients wearing this device for a year. We're very excited to be in the midst of a pediatric trial, essentially the same trial now for subjects 7 to 13 years of age. We have 71 enrolled, 27 have already entered now the pediatric continued access program, and we've had no severe hypoglycemia and no DKA to date in these subjects as well. We finished some feasibility studies, and we do think that this device could be safe for 2 to 6 year olds, so we're going to start enrolling them in 2 cohorts. First, the 5 to 6 year olds, prove safety with them, and then go on to the 2 to 4 year olds. And at the same time, we're preparing for a very large 1,000-patient randomized post-approval study that will be over a year's time period. The randomization will be over 6 months, and then we'll follow all of them afterwards on hybrid closed loop. There'll be 3 arms to this study: people coming from MDI, people coming from pump alone, people coming from sensor augmented pump therapy. We'll be looking at all ages, all durations of diabetes, and essentially very few exclusion criteria. And we'll conduct this study in multiple sites in the United States, as well as Canada and Europe. This is an exciting new therapy. I think it has a lot to offer our patients. It changes the paradigm a little bit of what we do, but all for the better. And that if the pivotal trial, as it gets translated out to a broader and broader population, we'll see that we will be able to improve patient outcome and reduce the burden of managing this disease. So I thank you all for your attention, and I can't wait to hear how you feel about our MiniMed 670G system as you get to use it with your patients.